Welcome back to the New York State Department of Health's Clinical Education Initiative's Building Blocks for Trans and Gender Diverse Care series. I'm Erica Bostic, my pronouns are she and her, and I'm an adolescent medicine physician and faculty for the CEI Sexual Health Center of Excellence.
And I'm Kai, my pronouns are he, him, and I'm a clinical educator with CEI.
So, we've walked you through the waiting room, literally, and interacted with other clinical staff in an inclusive manner. Now we are entering the clinical encounter. Let's talk about an affirming history and physical exam.
This is a series about trans and gender diverse people getting healthcare. In the coming videos, we will talk about some care that is very specific to this patient population. But before we can talk about hormones and gender affirming surgery, we first need to be able to obtain the necessary information to provide healthcare in an inclusive way.
Like any encounter with a cisgender person, I like to start with an introduction. Something along the lines of, "Hi, I'm Dr. Bostic. My pronouns are she, her, hers. What name and pronouns do you go by?"
As we've already talked about, people receive messages in a variety of ways. Some of them are through the words that we say, other messages are more visual. So consider using a pronoun badge or pin on your lapel, or some other sign of solidarity with the LGBTQ+ community, as folks will probably take note of them.
So we are going to go through each part of the H&P, or history and physical, for a new patient, including chief complaint, history of present illness, past medical, surgical, and family history, medications and allergies, social history, some pearls about the exam, and assessment and plan.
And while much of this will be the exact same whether your patient is cis, trans, or non-binary, we'll point out some specifics that are more pertinent when your patient identifies as trans or gender diverse.
Before the patient walks in, I prep my chart with the information I know based on the forms that we discussed in earlier episodes. This gives me a snapshot of who the person is as a building block to our upcoming discussion. It is helpful to note here that a person may choose to disclose their gender being different than assigned at birth or not. Existing parts of the medical record can be helpful and pertinent to a transgender or gender diverse patient. For example, past surgical history may show gender-affirming surgeries. Medication lists may show testosterone or estradiol. Having this information ahead of time allows me to confirm what I need to know with the patient, but not dwell upon it longer than is necessary. Electronic health records, or EHRs, are not perfect, but some improvements have been made. You may want to find out if your EHR has an organ inventory somewhere, or a place where SOGI, or sexual orientation gender identity data, is documented. This is helpful to have ahead of time and also may lead to an opportunity to update it with the patient as well.
All right, so let's talk about some things that I would not do. Don't be so stuck on your chart prep that you're making assumptions as to what the person walking through the door is going to look like. Because inevitably, your expression is going to indicate that you're surprised, and that's not going to look particularly welcoming to your patient. So be consciously aware of this. Know that you're human, and check your assumptions at the door.
We want to know what is bringing this patient into the office today, and what their goals of the visit are. Starting with a, "Hi there, what brings you in today?" gets straight to the point.
The most important thing to know when eliciting a chief complaint or history of present illness is to recognize that you are using your skills as a listener. Transgender and gender diverse patients commonly report that they state their chief complaint, and somehow that morphs into talking about their transition. There's even a name for this. It's called trans broken arm syndrome. And what it means is that all too often, trans people walk in complaining about something like pain in their arm, and instead of being asked questions about that arm pain, they get asked questions about their gender. Mostly because the person doing the interview is more interested in their gender and genitalia than they are in diagnosing a broken arm. So while the cis person might get their diagnosed broken arm x-rayed right away, a transgender person might end up with a whole series of uncomfortable questions and physical exam steps first.
Past medical history, often pretty straightforward regardless of gender. Depending on your specialty, this part of the history may get into gendered body parts. For example, if you ask about a history of abnormal pap smears, you are going to have to talk about the cervix and possibly the vagina. Or the prostate. If there are prostate concerns, you're going to have to ask if a person's ever been screened. It can be helpful to set ground rules about language that the patient does or does not want to use.
Time for another episode of What Would Kai Not Do? I would not ignore it when a patient is giving me cues. If a patient said that they had chest surgery, I would not then refer to it as breast reduction. I would listen to the cues they're giving me, both verbal and nonverbal, and follow suit.
Surgical history. This can be updated in the chart so everyone is on the same page. This may also prevent unnecessary reminders, such as a PAP reminder for a trans guy who no longer has indication for a PAP. For example, no longer has a cervix.
Another what would Kai not do? I would not ask if a patient had or plans to have the surgery. Why? Because there's no such thing as the surgery. There are a lot of different surgical options for transgender people who want to modify their bodies to bring them into better alignment with who they are. There's options from facial feminization to chest reconstruction to hysterectomy to bottom surgeries, including vaginoplasty or phalloplasty. There's no such thing as one surgery, so I wouldn't ask a patient if they've had the surgery. It's stigmatizing and not actually accurate.
Family history. Also quite straightforward regardless of gender. However, there are a few things to pay particular attention to in the context of hormone replacement therapy, such as personal or family history of breast cancer and personal history of migraines with aura. This is a good time to recognize that patients may not have the best knowledge of their biological families and being aware of language regarding family. For example, mom or dad. Knowing that family structure looks all sorts of ways and not making an assumption as to who composes this patient's family. Medications and allergies. Pretty straightforward. However, here is where you may take note of gender-affirming hormones such as estradiol, testosterone, or anti-androgen medications. You also may want to take note about certain meds that may interact or require further conversation in the context of hormone replacement. More to come on that. Sometimes seeing hormones on a med list is the first sign that a trans patient is trans, especially if they have been established for a long time. If you are not sure what to make of this, that's okay. You can always ask, tell me more about that medication.
So what would Kai not do? I would not take the electronic health record's word that these are all of the medications that a patient is currently taking or that the dose is accurate. This is going to be true for every patient, but you want to pay particular attention to this for your transgender and non-binary patients. With access to affirming care being so limited in the trans community, we know that some patients feel like they have to get their hormones outside of the medical system. And you definitely need to know if this is happening.
Social history. Lots to discuss here, and really important to set the stage in terms of creating a non-judgmental space and emphasizing confidentiality. As an adolescent medicine doc, this is my jam. Regardless of how you want to structure it, there are key components that must be covered to provide comprehensive care, even if you feel uncomfortable asking. Imagine how the patient will feel. So, here are some ideas of how to go about this. One that I use is a mnemonic, the HEADS mnemonic. The H, E, and A of HEADS stands for Home, Education/Employment, and Activities. Depending on your specialty and time constraints, these aren't absolutely essential to ask at every single visit with the patient. The idea here is by asking about these things, you not only can get a better sense of who they are, but also screen for things that you may be able to assist with. For example, by asking who lives in the home, you can assess for domestic violence, homelessness, and if they are homeless, why? Were they thrown out because of their gender identity? Education and employment. Are they unemployed or underemployed? Maybe social or career services could be a resource. Is there any harassment going on at work or at school? This may present an opportunity to review legal rights of that person in the school and the workplace. Activities. Here you can assess if the person is isolating or so busy that maybe there's more to talk about in terms of prioritizing health if need be.
What would Kai not do? I wouldn't make assumptions. We talked about how unemployment, underemployment, and housing instability might be an issue for transgender and non-binary patients, but certainly not all of them. So don't make any assumptions, and you're better off.
Okay, here comes the essential and potentially most uncomfortable parts of the social history for both provider and patient. I preface the conversation with something like, I have to ask you some personal questions now. not because I'm nosy, but because I want to be sure that I'm addressing you as an entire person, body, mind, and soul. All of this remains confidential unless, and particularly in the case of a minor, there is a direct safety concern, in which case we'll have to talk about that. Drugs. It's important to screen for substance use and substance use disorders for all patients. For instance, any drugs or substances that you use on a regular basis, this may include drugs that are injected into the body like heroin, or even pills that aren't prescribed to you. What about tobacco or vaping? If someone reports substance use, this is an opportunity to understand what role that substance is playing in their life, positive or negative, and if there are any resulting impairments. You can assess stage of change, take a harm reduction approach, and offer chemical dependency or smoking cessation resources if appropriate. The other thing to keep in mind in the context of gender-affirming hormones is the association between tobacco, and unknown for vapes, and negative health outcomes, which we'll talk more about later. Sexual history. Be clear about the purpose. This is about risk assessment and prevention, not about curiosity. This may also be the point in the visit where if it isn't already clear or disclosed, you may want to screen for gender identity. Something like, I ask all my patients the following questions. It says in the chart that you were assigned, say, female at birth. Is that how you identify now? If the patient's gender identity is different than the sex assigned at birth, this may be an opportunity to ask if they would like this to be reflected in the EHR.
What would Kai not do? I would not assume that just because a patient has come out to me, that they are out or want to be out to the entire medical system, their family, etc. You might be acting out of the best intention by changing their gender identity in electronic health record without letting them know, but doing that without the patient's permission may actually be putting them in harm's way.
More on the sexual history. It is important to remove gendered language. Being open to sex looking different for different people, understanding the meaning of sex in that person's life, and taking an overall sex-positive approach. This will allow you to get the information you need in a way that isn't all doomy and gloomy.
What would Kai not do? I would not make assumptions about a person's sex life based on how they identify and what they look like. Sex isn't a driving force for all people, which is okay too. So don't forget that your patient may be asexual, and that's perfectly normal.
Safety. Some of this may already have been covered. For all patients, you want to assess for safety. Safety in themselves and safety when around others, meaning screening for suicidal ideation, self-injurious behavior, bullying, harassment, abuse. We have reviewed the minority stress model in previous videos and the cumulative effects of anti-trans legislation and beliefs that have led to higher rates of homelessness, sexual assault, depression, suicide, and more for the trans community.
But don't be afraid to go there. You don't want to assume these things are going to be positive for your trans patients and negative for cis patients. The reality is, the world isn't the safest place for a trans person, and you may be a person to help. That being said, don't go there if you aren't ready to act, or if your actions might actually make things worse. For example, if you discover that your trans patient is unstably housed, don't suggest that they go to a homeless shelter that actively discriminates against trans people. This is only going to make matters worse.
Physical exam. Just like the history, the physical exam is a time where you need to let the patient know what you're doing and why you're doing it. You would do this with any patient, but it's particularly important with a trans patient. If you don't do this, trust can be eroded quickly, especially if a patient is expecting to walk in the door and be mistreated, which sadly often is the case. Also be sure to try and use gender-neutral language or reflect back the language that the patient has already established as being comfortable.
What would Kai not do? I would not let my patient feel like they were on display. The literature is riddled with examples of this. For example, patients telling stories where a doctor had them sitting on their exam table, left the room, and returned with 5 medical students because the patient was, quote, such an interesting case.
Next up, we will use what we learned here and simulate a telemedicine visit between a provider and a trans patient. See you soon.